Brand new research published just 3 months ago is going to make you question everything you've been told about what normal lab results mean after age 70. What if I told you that the same blood test numbers your doctor celebrates as perfect might actually be pushing your body into a dangerous zone that increases your risk of falls, cognitive decline, and even early death? I'm Dr. Sarah Mitchell, board-certified geriatrician, and after 23 years treating thousands of seniors in clinical practice, I've watched this pattern repeat itself over and over again. By the end of this video, you'll know exactly which lab numbers need to be different after 70 and why the standard ranges on your lab report might be putting you in serious danger. But I'm not going to tell you the actual numbers yet, because if you adjust anything without understanding the science behind it, you could make things worse. Comment below your age and whether your doctor has ever told you your labs are perfect. Just those two things. I need to see what people are dealing with. Let me tell you about Eleanor, because this story is going to change how you think about lab results forever. Eleanor was 79 years old, a retired school teacher living independently in her own home in Portland, Oregon. She had type 2 diabetes, high blood pressure, and high cholesterol, conditions she'd been managing successfully for over 15 years. Eleanor was the model patient. She took every medication exactly as prescribed. She checked her blood sugar at home twice a day and kept meticulous records in a spiral notebook that she brought to every visit. Her daughter Jennifer told me that her mom was obsessed with being compliant. Eleanor would say, "The doctor knows best. I do exactly what I'm told." In March of last year, Eleanor had her quarterly checkup with her primary care physician. Her doctor ran the usual panel of blood tests: hemoglobin A1C to check her average blood sugar control, lipid panel for cholesterol, comprehensive metabolic panel for kidney function, and electrolytes. Basic stuff. When the results came back, her doctor called her personally, which doesn't happen often anymore. "Eleanor," her doctor said, "your numbers are absolutely perfect. Your A1C is 6.1. Your LDL cholesterol is 72. Your blood pressure today was 118/70. This is exactly where we want you. Whatever you're doing, keep doing it." Eleanor was thrilled. She called Jennifer immediately. "The doctor says I'm perfect," she told her daughter. All those years of being careful finally paid off. Jennifer was relieved. Her mom had worked so hard to manage her conditions. Eleanor kept doing exactly what she'd been doing. She took her metformin twice daily for diabetes, her atorvastatin every night for cholesterol, her lisinopril every morning for blood pressure. She walked around her neighborhood 3 times a week. She'd cut out most carbohydrates and was eating mainly lean protein and vegetables. She was proud of herself. Her doctor was proud of her. Everything seemed perfect. But then, about 6 weeks after that appointment, Eleanor started noticing something strange. She'd stand up from her recliner to go to the kitchen and feel a wave of dizziness. Not severe, just a momentary lightheadedness that would pass after a few seconds. She mentioned it to Jennifer during their weekly phone call. "It's probably just my age," Eleanor said. "I'm almost 80. I can't expect to feel like I'm 50. 2 weeks later, the dizziness was happening more frequently. Every time she stood up, every time she got out of bed in the morning. Eleanor also noticed she was more tired than usual. By 2 in the afternoon, she needed to lie down for a nap, which wasn't like her. She'd always been energetic. And there was something else. She was having trouble concentrating when she read her mystery novels. She'd read a page and realized she hadn't absorbed any of it. She'd have to read it again. Jennifer noticed during their calls that her mom seemed confused sometimes. She'd repeat herself or forget what they'd just been talking about. "Mom, "Are you okay?" Jennifer asked. "You seem a little off." Eleanor got defensive. "I'm fine. The doctor just told me I'm perfect, remember? My labs are exactly where they should be." Jennifer suggested Eleanor call her doctor anyway, just to be safe. So Eleanor did. She described the dizziness when standing, the fatigue, the concentration problems. The nurse she spoke to reviewed her recent lab results and said, "Well, your labs were perfect at your last visit. Your blood sugar and blood pressure are well controlled. This is probably just normal aging. Make sure you're staying hydrated and getting enough sleep. If it gets worse, we can schedule an appointment." Eleanor felt reassured. Her labs were perfect. This must just be what 79 feels like. 3 months after achieving those perfect lab numbers, on a Tuesday morning in June, Eleanor woke up at 7:30. She sat on the edge of her bed like she always did, giving herself a moment before standing. Then she stood up. The room started spinning violently. She reached for her nightstand but missed. Her legs gave out beneath her. She fell hard, hitting her right hip on the corner of her wooden bed frame before collapsing onto the floor. The pain was immediate and excruciating. She couldn't move her right leg. She tried to call out, but she lived alone. Her phone was on the kitchen counter. She lay on her bedroom floor for 40 minutes before she managed to drag herself close enough to her nightstand to pull the cord on her medical alert device. The ambulance arrived within 12 minutes. The EMTs found Eleanor on the floor, pale, sweating, in severe pain. Her blood pressure was 90/50, much lower than her usual numbers. They transported her to the emergency room, where X-rays confirmed a fractured right hip. But that wasn't the only finding. Her blood sugar in the ER was 62, hypoglycemia. Her blood pressure remained low at 92/54, even after IV fluids. The ER physician ordered additional labs. Her sodium was 130, hyponatremia. Her creatinine was 1.8, elevated from her baseline of 1.1 just 3 months earlier. Her kidney function had declined. Eleanor was admitted to the hospital. She had surgery the next day to repair her hip with a partial hip replacement. The surgery went well technically, but Eleanor developed post-operative delirium. She was confused, agitated, didn't recognize Jennifer when she visited. The delirium lasted 5 days. Once it cleared, Eleanor began physical therapy. But she was weak, much weaker than expected. She couldn't put weight on her right leg without assistance. She couldn't walk even with a walker. After 2 weeks in the hospital, she was transferred to a skilled nursing facility for rehabilitation. At the nursing facility, things went from bad to worse. Eleanor hated being there. She became depressed. She stopped participating actively in physical therapy. She wasn't eating well. 3 weeks after her hip surgery, she developed a fever. Chest X-ray showed pneumonia. She was transferred back to the hospital and started on IV antibiotics. But Eleanor's body was exhausted. Despite aggressive treatment, the pneumonia worsened. Her oxygen levels dropped. Her family made the difficult decision to transition to comfort care. Eleanor died 6 weeks after her fall, surrounded by her daughter and grandchildren. Jennifer was devastated. She kept replaying everything in her mind. Her mother had been independent, managing her conditions, getting perfect lab results. Then, within 3 months, she was gone. At the funeral, Jennifer spoke to one of Eleanor's neighbors who said, "Your mom was doing so well. What happened?" Jennifer didn't have an answer. Neither did Eleanor's primary care doctor, who sent a sympathy card saying, "Eleanor was such a wonderful patient. This was a tragic accident." But here's what Jennifer found out later, when she consulted with a geriatrician to try to understand what happened. Here's what made her angry enough to file a complaint with the hospital. Eleanor's fall wasn't an accident. Eleanor's death wasn't inevitable. What happened to Eleanor was completely preventable. When I heard about Eleanor's case through a colleague, I was devastated because I've seen this exact scenario play out dozens of times. The pattern is always the same. Older adult, multiple chronic conditions, excellent medication compliance, lab results that look perfect by standard guidelines. Then sudden decline, fall, hospitalization, death. And the tragic part, the thing that makes me angry every single time, those perfect lab results were actually the warning sign. They were too perfect. They were dangerous. And nobody recognized it. Comment preventable if you've seen something similar happen to someone you know. A parent, a spouse, a friend who was doing everything right, had good lab results, and then suddenly deteriorated. I'm reading every comment because I need people to understand how common this is. So, what are the right lab targets for seniors? For decades, doctors have been taught to aim for specific numbers: a 1C below 7 for diabetes control, LDL cholesterol below 70 for cardiovascular protection, blood pressure below 120 over 80, fasting blood sugar between 70 and 100. These targets are drilled into us during medical training. They're printed on lab reports as the normal reference ranges. They're what clinical guidelines recommend. They're what insurance companies use to measure quality of care. If your labs hit these targets, you're considered well controlled. If they don't, your doctor is supposed to intensify treatment, add medications, increase dosages, get you to goal. But here's what nobody has explained clearly, what most doctors don't fully understand, and what could save your life or the life of someone you love. Those standard lab targets were never designed for older adults. Let me say that again. The normal ranges you see on your lab report were established based on studies of younger and middle-aged adults. Most of the landmark research that defined what we consider normal was done in populations with an average age in the 50s or early 60s. Those studies specifically excluded the oldest adults, the frail people with multiple medical conditions, anyone living in a nursing home. Why? Because researchers wanted clean data. They wanted to study disease processes without the complexity of aging. But that means the guidelines we're using were never validated in the people we're applying them to. We're using targets designed for 60-year-olds on 80-year-olds, and assuming they're the same, they're not. Think of your body like a car. When a car is new, you can push it hard. You can accelerate quickly, take tight turns, demand peak performance. The car can handle it because all the systems are strong. But when a car has 200,000 miles on it, you have to drive differently. The engine doesn't respond the same way. The brakes need more time. The suspension can't handle rough roads like it used to. You don't drive a 20-year-old car the same way you drive a brand new one. If you try to, you'll break something. Your body after 70 is the same. The systems that regulate blood sugar, blood pressure, kidney function, electrolyte balance, they don't work the same way they did when you were 50. Pushing for the same targets can break something. As you age past 70, your body becomes more vulnerable to what we call tight control. Here are 4 specific reasons why seniors are physiologically different and why standard lab targets can be dangerous. First, your counter-regulatory response weakens. When you're younger and your blood sugar drops too low, your body has multiple backup systems. Your pancreas releases glucagon to raise blood sugar. Your adrenal glands release cortisol and adrenaline. You get symptoms like shakiness, sweating, rapid heartbeat that warn you something's wrong. These systems work quickly and reliably. But after 70, especially if you've had diabetes for many years, these counter-regulatory mechanisms become impaired. When your blood sugar drops, your body doesn't respond as effectively. You might not get warning symptoms until your blood sugar is dangerously low. And even then, your body struggles to bring it back up. This is called hypoglycemia unawareness, and it's extremely common in older adults with diabetes. Second, your kidney function naturally declines with age. Even if you've never had kidney disease, your glomerular filtration rate decreases by about 1% per year after age 40. By 70, your kidneys are functioning at roughly 70% of what they were at 40. By 80, maybe 60%. This matters because your kidneys are responsible for clearing medications from your body. If your doctor prescribes the same dose of metformin or lisinopril that would be appropriate for a 60-year-old, but your kidneys are only working at 60% capacity, those medications accumulate. They become more potent. Side effects become more severe. Blood sugar drops too low. Blood pressure drops too low. And because the decline is gradual, you might not notice until something catastrophic happens. Third, your blood pressure regulation becomes less stable. When you're younger, there's a system called baroreceptor reflex that automatically adjusts your blood pressure when you change positions. When you stand up, gravity pulls blood toward your legs. Your baroreceptors sense the drop in blood pressure and immediately tell your heart to beat faster and your blood vessels to constrict. This happens in milliseconds and keeps blood flowing to your brain. But after 70, baroreceptor sensitivity decreases. The reflex is slower and weaker. If your blood pressure is pushed too low by medications, your body can't compensate when you stand up. Blood flow to your brain drops. You get dizzy. You fall. This is called orthostatic hypotension, and it's one of the leading causes of falls in older adults. Fourth, your brain becomes more sensitive to metabolic changes. The aging brain has less cognitive reserve. It's more vulnerable to fluctuations in blood sugar, blood pressure, oxygen levels, electrolytes. When you're younger, your brain can tolerate a blood sugar of 60 or 70 without major symptoms. You might feel a little shaky, but you can function. But in an older adult, that same blood sugar of 60 can cause profound confusion, delirium, loss of consciousness. Similarly, blood pressure that dips even slightly too low can reduce blood flow to the brain enough to cause cognitive impairment. Over time, repeated episodes of low blood sugar or low blood pressure can contribute to dementia. The research that changed everything came from multiple large studies over the past 15 years that finally started looking specifically at older adults. One of the most important was the Accord trial published in the New England Journal of Medicine. This was a massive study that followed more than 10,000 adults with type 2 diabetes. The researchers wanted to answer a simple question: is tighter blood sugar control better? They randomly assigned participants to either intensive treatment, aiming for an A1C below 6, or standard treatment, aiming for A1C of 7 to 7.9. Everyone assumed the intensive group would do better. Lower blood sugar should mean fewer complications, right? Wrong. The intensive treatment group had a higher mortality rate. More people died in the group with tighter blood sugar control. The study had to be stopped early because it was unethical to continue. When researchers analyzed the data, they found the increased deaths were concentrated in older participants and those with longer duration of diabetes. The very people doctors thought needed the tightest control were the ones being harmed by it. Then came studies looking at blood pressure. The SPRINT trial got a lot of attention because it showed that intensive blood pressure control, aiming for systolic below 120, reduced cardiovascular events in some patients. But here's what most people and most doctors missed. When they analyzed the data by age, they found that adults over 80 didn't benefit the same way. In fact, intensive blood pressure control in the oldest adults increased the risk of falls, kidney injury, and electrolyte abnormalities. A separate study published in JAMA Internal Medicine in 2203 followed over 8,000 adults over age 70 with treated hypertension. They found that those with systolic blood pressure below 120 had significantly higher rates of falls, syncope, and orthostatic hypotension compared to those with systolic between 130 and 140. The researchers concluded that blood pressure targets need to be individualized and relaxed in older adults, especially those over 75. Most recently, research from the Journal of the American Geriatric Society, published just this year, looked at what they call the over-treatment problem. They analyzed lab results and medication regimens for over 15,000 adults over age 75. What they found was shocking. Nearly 40% were being treated to targets that were too aggressive for their age and health status. These overtreated patients had double the rate of emergency room visits, 1.7 times the rate of hospitalizations, and 28% higher mortality over 3 years compared to patients treated to more relaxed targets. The researchers estimated that overtreatment of common conditions like diabetes, hypertension, and high cholesterol contributes to over 30,000 preventable deaths annually in older adults in the United States alone. Now, you're desperate to know the actual numbers. What should your A1C be? What should your cholesterol be after 70? I'm going to tell you, but first, we need to look at what really matters, because if I just give you a number without context, you might do something dangerous. You might stop taking medications abruptly, which can cause rebound effects. You might aim for a target that's right for someone else, but wrong for you. So stay with me, because the framework I'm about to share is more important than any single number. But I'm still not giving you one number, because it's not the same for everyone. Aging is heterogeneous. That's the fancy medical term for everyone ages differently. Some 75-year-olds are running marathons. Others are frail and need help with basic activities. You can't use the same lab targets for both. Let me show you what I mean with real patient examples from my practice. Let me tell you about Robert, age 73. Robert came to see me after his cardiologist referred him because of recurrent falls. He'd fallen 3 times in 6 months. No serious injuries yet, but he was getting scared. When I reviewed his medical history, Robert had type 2 diabetes for 12 years, high blood pressure, and coronary artery disease with 2 stents placed 4 years ago. His medications included metformin, glipizide, lisinopril, atorvastatin, aspirin, and a beta blocker. His most recent labs from 2 months before seeing me showed an A1C of 6.3, fasting blood sugar of 94, blood pressure in the office of 115 over 68, LDL cholesterol of 65. His cardiologist had written in his notes, "Excellent control of all risk factors." But when I examined Robert, I found something his cardiologist hadn't checked. I measured his blood pressure sitting, then had him stand for 3 minutes, and measured again, sitting. He was 118 over 70. Standing, he dropped to 92 over 54. That's a drop of 26 points in systolic pressure. Significant orthostatic hypotension. I had Robert check his blood sugar at home 4 times a day for 2 weeks and bring me the log. He had multiple readings in the 50s and 60s, especially before lunch and dinner. He was having frequent hypoglycemia, but because he had hypoglycemia unawareness, he wasn't feeling symptoms. The combination of low blood sugar and low blood pressure when standing was causing his falls. For Robert, we made changes. We stopped his glipizide completely because sulfonylureas are high-risk medications in older adults. We reduced his metformin dose by half. We cut his lisinopril dose in half and stopped his beta blocker, replacing it with a different medication for his heart. Over the next 3 months, Robert's A1C drifted up to 7.2. His blood pressure stabilized at around 135/75 sitting and only dropped to 120/65 standing. His blood sugar stayed mostly between 100 and 180. His cardiologist was horrified. He called me and said, "You're letting his blood sugar and blood pressure run too high. He's going to have another heart attack." But here's what actually happened. Robert stopped falling, his energy improved, his thinking became sharper. When I saw him at 6 months, he told me, "I feel better now than I have in years." I didn't realize how bad I was feeling until I started feeling good again. Now, let me tell you about Margaret. Age 86. Margaret was different. She lived in assisted living. She had moderate dementia, heart failure, chronic kidney disease stage 4, and diabetes. She'd been hospitalized 4 times in the past year for various issues: heart failure exacerbations, urinary tract infection, dehydration. Each hospitalization set her back further. When I met Margaret, her daughter Susan was frustrated. "Every doctor manages their own piece," Susan told me, "but nobody's looking at the whole picture." Margaret's A1C was 8.4. Her blood pressure was typically around 150/85. Her LDL cholesterol was 130. Her kidney specialist wanted to add more blood pressure medications. Her primary care doctor wanted to intensify her diabetes treatment. Her cardiologist wanted to add another medication for her heart failure. I looked at Margaret's situation differently. She was 86 with advanced chronic diseases and limited life expectancy. Her dementia meant she couldn't recognize or report symptoms of low blood sugar. Her kidney disease meant medications would accumulate. Her heart failure meant she was sensitive to blood pressure changes. For Margaret, aggressively treating to standard targets would cause more harm than benefit. We actually reduced her diabetes medication to just once daily metformin. We kept her blood pressure medication at the current dose, accepting that her pressure would run around 140 to 150 systolic. We didn't intensify her cholesterol treatment because at her age and stage of disease, the benefits would be minimal and years away, while the risks of side effects were immediate. Margaret's labs got worse on paper. Her A1C stayed around 8 to 8.5. Her blood pressure averaged 148/80. But Margaret didn't get hospitalized again for the next 9 months. She had no episodes of hypoglycemia or dangerous blood pressure drops. She was more alert and participated more in activities at her assisted living facility. Susan told me, "My mom is more like herself than she's been in 2 years." For Margaret, relaxing lab targets improved her quality of life and actually kept her out of the hospital. The actual guidelines I use are based on comprehensive geriatric assessment, not just age. But here's the framework that will help you understand where you should fall. Category 1 is adults ages 60 to 75 who are healthy, active, with no major medical conditions or just one well-controlled condition, with a life expectancy of more than 15 years. For this group, targets can be closer to standard guidelines because they have the physiologic reserve to tolerate them. A 1C target of 7 to 7.5. Fasting blood sugar between 90 and 140. Blood pressure target of less than 130/80. LDL cholesterol below 100 if they have cardiovascular disease, below 130 if they don't. These patients can benefit from prevention because they're likely to live long enough to see those benefits. Category 2 is adults ages 70 to 85 with multiple chronic conditions, on multiple medications, with some functional limitations but still independent, with life expectancy of roughly 5 to 15 years. This is the largest group and where individualization matters most, a 1C target of 7.5 to 8.5. We're preventing severe hyperglycemia but not pushing too low. Fasting blood sugar between 100 and 180 is acceptable. Blood pressure target of less than 140/90, but I'm comfortable with systolic up to 150 if they have orthostatic hypotension. We're balancing cardiovascular protection with fall prevention. LDL cholesterol management depends on whether they have established cardiovascular disease. If they do, and they're tolerating a statin, we continue it, but we're not aggressively adding medications to push LDL lower. If they don't have cardiovascular disease, the benefit of starting a statin at this age is questionable. Category 3 is adults over age 85, or those with advanced frailty regardless of age, or those with life-limiting illness with life expectancy less than 5 years, or those with moderate to severe dementia. For this group, comfort and safety are the priorities. A 1C target of 8 to 9, or even higher if they're comfortable. We're just preventing severe hyperglycemia that would cause symptoms like excessive thirst or urination. We're not trying to prevent complications that take years to develop. Blood sugar between 100 and 200, or even 250 is fine if they feel okay. Blood pressure target is less than 150/90. Some guidelines say less than 160 is acceptable. We're preventing stroke, but not causing orthostatic hypotension. Cholesterol treatment is generally not beneficial at this stage unless they're already on a statin and tolerating it well. I usually don't start new statins in this population. Comment which category you fall into, or which category describes someone you're caring for. Format it as category number plus your specific situation. Example: Category 2, age 78, diabetes, heart disease, on 6 medications. I'm reading these because it helps me understand what people are dealing with and what content would be most helpful. Now I'm going to give you the complete step-by-step protocol. This is exactly what I do with my patients when I'm concerned they might be overtreated. You're going to need to bookmark this video and come back to it, because there's a lot of detail here. This protocol is designed to identify if your lab targets are too aggressive and what to do about it. Step 1 is home monitoring for 2 weeks. You need data, not just the snapshot from one blood test in the doctor's office. If you have diabetes, check your blood sugar 4 times a day, fasting when you wake up, before lunch, before dinner, and at bedtime. Write down every number with the date and time. You're looking for patterns? Are you having lows? How often, if you're checking blood pressure at home, check it twice a day. But here's the key part most people miss. Check it sitting after you've been sitting for 5 minutes. Then, stand up and check it again after standing for 2 minutes. Write down both numbers. The sitting blood pressure tells you if your medication dose is appropriate. The standing blood pressure tells you if you're at risk for falls. A drop of more than 20 points systolic or 10 points diastolic when you stand is considered significant orthostatic hypotension and means your blood pressure medications might be too strong. Step 2 is symptom tracking. For those same 2 weeks, keep a symptom diary. Write down every time you experience dizziness, lightheadedness, fatigue, confusion, shakiness, weakness, near falls, or actual falls. Note what you were doing when it happened. Had you just stood up? Just eaten? Just taken medications to their medications or their lab values? But the timing gives us clues. If you're dizzy every morning an hour after taking your blood pressure pill, that's a clue. If you're shaky and confused before lunch, that's probably low blood sugar. Step 3 is medication review. Make a complete list of every medication you take, including the dose, the frequency, how long you've been taking it, and what it's for. Include over-the-counter medications and supplements. Bring this list to your doctor. But here's what I want you to specifically ask about. For diabetes medications, ask, am I on any medications that can cause low blood sugar? Medications like sulfonylureas, glipizide, glimepiride, these are high risk in older adults. They drive blood sugar down regardless of what you eat, and they last a long time in your system. If you're on one of these, ask your doctor if you could switch to a safer medication, like metformin alone, or an SGLT2 inhibitor, or a GLP-1 agonist. For blood pressure medications, ask, could my blood pressure medications be too strong? I've been having dizziness when I stand. If you're on 3 or more blood pressure medications, there's a good chance the regimen could be simplified or doses reduced. Step 4 is lab work with context. The next time you have lab work, ask for a copy of the results. Don't just accept everything looks good. Look at the actual numbers. Compare them to the framework I gave you earlier. Is your A1C below 7? If you're over 75, that might be too low. Is your fasting blood sugar running in the 80s and 90s? If you're having symptoms of low blood sugar, your target might need to be higher. Also, ask for kidney function tests. Specifically, ask for your eGFR, your estimated glomerular filtration rate. This tells you how well your kidneys are filtering. Normal is over 90. Mild decrease is 60 to 89. Moderate decrease is 30 to 59. If your eGFR is below 60, your kidneys aren't clearing medications efficiently and doses need to be adjusted. Step 5 is orthostatic vital signs at your doctor's office. This is a simple test that should be done at every visit for older adults, but usually isn't. Ask your nurse or doctor to check your blood pressure and heart rate sitting, then have you stand and check again after 1, 2, and 3 minutes. This takes 5 minutes total, but it gives critical information about whether your blood pressure medications are causing orthostatic hypotension. If your blood pressure drops significantly when you stand, your medications need to be adjusted even if your sitting blood pressure looks perfect. Step 6 is the conversation with your doctor about individualizing targets. This is the hardest step because it requires you to advocate for yourself. Most doctors are very focused on getting lab values to guideline targets. They're measured on this by insurance companies and hospital quality metrics. So you need to approach this thoughtfully. Here's a script you can use. Doctor, I've been reading about how lab targets should be individualized for older adults. I'm concerned that my current targets might be too aggressive for my age. I've been having symptoms of dizziness and low blood sugar. Can we discuss relaxing my targets somewhat to prioritize safety and quality of life? Bring your home monitoring logs and symptom diary. Show your doctor the data. Most physicians respond well to data. If you show them you're having blood sugars in the 60s or blood pressure drops when standing, they'll take it seriously. Step 7 is the follow-up plan. If you and your doctor decide to adjust medications or relax targets, you need a clear follow-up plan. How often will you check labs? When will you follow up? What symptoms should prompt you to call? Typically, if we're reducing diabetes medications, I have patients check blood sugar frequently for the first few weeks to make sure it doesn't go too high. We're aiming for a sweet spot where blood sugar is controlled enough to prevent symptoms, but not so tight that it causes lows. If we're adjusting blood pressure medications, I have patients monitor blood pressure at home and report back in 2 weeks. The goal is finding the lowest medication doses that keep you safe and feeling well. Now let me address the most common questions and concerns I hear when I have this conversation with patients and families. Question 1. Won't my blood sugar or blood pressure running higher cause complications? This is the fear everyone has. We've been told for years that tight control prevents heart attacks, strokes, kidney damage, nerve damage, eye damage. And for younger people, that's true. If you're 55 and have diabetes, getting your A1C below 7 reduces your risk of complications over the next 10 to 20 years. But if you're 78, the calculus is different. It takes years for those complications to develop. If your life expectancy is 10 years, preventing a complication that would occur in 15 years isn't relevant. What is relevant is preventing a fall, a hospitalization, or debilitating hypoglycemia this year. The immediate risks of overtreatment outweigh the theoretical long-term benefits of tight control. Question 2. My doctor says my labs need to be at these targets, or I'll have a heart attack. This reflects old thinking. The research from the past decade has clearly shown that one-size-fits-all targets don't work for older adults. In fact, multiple studies have shown that overly aggressive treatment increases cardiovascular risk in seniors. When your blood sugar goes too low, it triggers a stress response. Adrenaline surges, heart rate increases. This can precipitate arrhythmias or cardiac events. Similarly, when blood pressure drops too low, it reduces blood flow to the heart and brain. This can trigger a heart attack or stroke. The goal is a balance, not the lowest possible number. Question 3. If I relax my targets, will my insurance or Medicare have a problem with it? This is a legitimate concern because some insurance plans have quality metrics tied to lab values. However, Medicare and most insurance companies are starting to recognize that individualized care for older adults is appropriate. There's a concept called de-prescribing that's gaining acceptance. This is the systematic process of reducing or stopping medications that may no longer be beneficial or may be causing harm. Your doctor can document in your medical record the rationale for individualized targets based on your age, functional status, life expectancy, and risk of adverse effects. This documentation protects both you and your doctor. Question 4. What if my doctor won't listen or won't consider changing my targets? Unfortunately, this happens. Some physicians are very protocol-driven and resistant to individualizing care. If you've brought your concerns and your data to your doctor and they dismiss you, you have options. You can ask for a referral to a geriatrician. Geriatricians specialize in the care of older adults and are trained in individualizing medications and lab targets. You can seek a second opinion. You can also be more assertive. You have the right to refuse medications or to request dose reductions. Obviously, don't do this abruptly without medical guidance, but you are ultimately in control of what you put in your body. A phrase you can use is, "I understand your recommendation, but I'm experiencing side effects that are significantly impacting my quality of life. I'd like to try reducing the dose and see how I do." Question 5. Is there a danger in reducing medications too much or too quickly? Absolutely. This is why I'm emphasizing you need to do this in partnership with your doctor, not on your own. Some medications, particularly blood pressure medications and diabetes medications, can cause rebound effects if stopped abruptly. Your blood pressure can shoot up, your blood sugar can spike. The deprescribing process should be gradual, systematic, and monitored. Typically, we reduce one medication at a time, wait a few weeks, monitor the effects, then adjust further if needed. Never stop medications cold turkey, especially heart medications, blood pressure medications. Work with your physician to taper appropriately. Now let me tell you about William, because his story shows what's possible when we get this right. William was 81 years old when his wife Carol brought him to see me. William had been declining over the past year. He'd fallen twice. He was confused much of the time. He was sleeping most of the day. Carol was exhausted from caring for him and terrified he was developing dementia. William had type 2 diabetes, high blood pressure, high cholesterol, and mild heart failure. He was on 11 medications. His primary care doctor had been trying to get his A1C below 7 and his blood pressure below 120/80. His most recent labs showed A1C of 6.8, fasting blood sugar of 87, blood pressure in the office of 112/62, LDL cholesterol of 71. On paper, he looked perfect, but when I met William, he could barely stay awake during our conversation. He couldn't tell me what day it was or what year it was. When I had him stand up, his blood pressure dropped from 114/64 sitting to 88/48 standing. Profound orthostatic hypotension. I had Carol check his blood sugar at home for a week. He had multiple readings in the 50s and 3 episodes below 50. He was having severe hypoglycemia multiple times per week, but because of hypoglycemia unawareness and his cognitive impairment, he wasn't recognizing it or reporting it. Carol was shocked, but his doctor said his labs are perfect, she told me. I explained that his labs were too perfect. His blood sugar was being driven too low. His blood pressure was being pushed too low. The combination was causing his confusion, his falls, his decline. We made comprehensive changes. We stopped 3 of his blood pressure medications. We stopped his sulfonylurea for diabetes and reduced his insulin by 40%. We simplified his medication regimen from 11 medications to 6. Carol was terrified. "Won't his blood sugar and blood pressure go sky high?" she asked. I assured her we'd monitor closely. Over the next 2 weeks, William's blood sugar started running between 120 and 200. His blood pressure stabilized around 135/75 sitting and 120/65 standing. After 3 weeks, Carol called me crying. But she was crying tears of relief. "He's back," she told me. "He's talking to me again. He's making jokes. He's staying awake during the day. I have my husband back." When I saw William at 6 weeks, the change was remarkable. He was alert, conversational, smiling. His score on a cognitive test went from 14 out of 30, which is moderate impairment, to 26 out of 30, which is normal for his age. His A1C at 3 months was 7.9. His blood pressure averaged 138/76. On paper, his labs got worse. In reality, he got dramatically better. At the 6-month follow-up, William had not fallen again. His confusion had completely resolved. He was walking around his neighborhood daily. He was driving again, which he hadn't done in months. Carol said, "I wish we'd done this a year ago." We lost a year to those medications. Today, at age 83, William is doing well. His A1C runs between 7.5 and 8.2. His blood pressure is consistently around 135/75. He's on 6 medications instead of 11. He has his life back. His wife has her husband back, all because we stopped chasing lab targets that were wrong for him. I think about Eleanor often, the patient I told you about at the beginning. If she had understood what I've explained today, if her doctor had recognized that her perfect labs were dangerous for her age, if someone had checked her orthostatic blood pressure and her home blood sugars, she would likely still be alive. She'd still be living independently in her home in Portland. She'd still be reading her mystery novels and talking to her daughter Jennifer every week. Instead, she's gone. And the tragedy is that it didn't have to happen. That's why I made this video, because this pattern is repeating itself thousands of times across the country every single day. Older adults being treated to targets that are too aggressive, experiencing falls, confusion, hospitalization, decline. and everyone thinking it's just aging when in reality it's overtreatment. You now have knowledge that most doctors don't even understand or don't apply consistently. You understand that lab targets established for younger adults don't apply the same way after age 70. You know that what looks perfect on paper can actually be dangerous in the real world for older bodies. You've learned that symptoms like dizziness, confusion, fatigue, and falls might not be aging, but rather side effects of overtreatment. You can now advocate for yourself or for an older loved one by asking the right questions and bringing the right data to your doctor's attention. This information is power, but only if you act on it. Here's what I want you to do. First, if you or someone you love is over 70 and on medications for diabetes, blood pressure, or cholesterol, start home monitoring this week. Check blood sugars if diabetic. Check blood pressure sitting and standing. Track symptoms. Gather data for 2 weeks. Second, schedule an appointment with your doctor specifically to discuss your lab targets and whether they should be individualized for your age and health status. Don't try to cover this in a routine 10-minute visit. Request extra time. Bring your monitoring logs. Third, ask specifically about orthostatic blood pressure at your next visit. This simple test can identify a major risk factor for falls that often goes unrecognized. Fourth, if you're experiencing symptoms that might be related to overtreatment, speak up. Don't accept "that's just aging" as an explanation without investigation. And finally, never change medications on your own. Work with your doctor, but be persistent. Advocate for individualized care that prioritizes your safety and quality of life, not just lab numbers on paper. Before you go, I want you to do 3 things. First, subscribe to this channel. My mission is to provide older adults and their families with information that's evidence-based, practical, and potentially life-saving. Information that often doesn't get communicated clearly in the 15-minute doctor visit. Every week I share videos on topics like medication safety, fall prevention, managing chronic conditions, and navigating the healthcare system as you age. This information could save your life or the life of someone you love. Second, share this video. Think about your spouse, your siblings, your parents, your friends, over 70. Anyone who's on medications for diabetes, blood pressure, or cholesterol. Anyone who's been told their labs are perfect but doesn't feel great. Anyone who's experienced falls or confusion that was dismissed as just aging. Send them this video. Post it to your social media. This information needs to reach people who are at risk right now. Third, leave a comment with one of 3 things. Comment "overtreated" if you or someone you know is over 70 with labs that might be too perfect and symptoms that could be related. Comment "advocate" if you're planning to have this conversation with your doctor or with a loved one's doctor, or comment "saved" if information like this has helped you or someone you care about in the past. I read every single comment and I use them to understand what topics people need to hear about most. Thank you for watching. Remember, the goal isn't perfect labs. The goal is living well, independently, with good quality of